And one thing that I think has surprised me, and maybe Claudia can talk about this too, is that we've gone into these interviews thinking that cost and inflation was going to be the number one issue that they faced. But every single one of them wants to talk about disruptions, right? There was a CSCO from a large health system this morning that we spoke with who gave me just a great quote. And what he said was, look, David, the cost of a back order is much greater than the cost of a widget right now. And I thought that was really, really powerful. And I think that speaks to some of the uncertainty that Andy's kind of talking about there.
Without supplies, there's no surgery. Without products, there's no patient care. Welcome to Power Supply, the healthcare supply chain podcast focused on helping you navigate the intricacies of logistics, purchasing, contracting, and supplier relationships. Each episode, we speak with healthcare executives, supply chain leaders, and innovative entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the loading dock to strategic sourcing, from buyers to the C-suite, and across the enterprise, we tackle the real-life issues impacting the healthcare supply chain. Whether you're tuning in for conversation or inspiration, we're glad you're here. You're just in time to hear it from the source and stock up on insight. So sit back and plug into Power Supply.
This week on Power Supply, we speak with Andy Balthrop, Claudia Rosales, and David Dobrzykowski with the University of Arkansas Sam M. Walton College of Business in Hays. We're going to be talking about the impact of inflation in healthcare. And I know we'll talk about the whole concept of inflation as it impacts all of us on a day-to-day basis. But everybody who listens to this episode, if you're in supply chain, you're not only feeling the crunch, but you've got some difficult conversations with suppliers that are going to be coming down the pike if they haven't started already. And I think just getting a handle on this and an understanding on whether or not this is a short-term or a long-term concern is something we're going to dive into today.
Yeah, I'm excited to do this because these guys and gals, they know their stuff. If you don't follow them on LinkedIn, you should, but they produce a ton of great research. And I do know we're going to get into a lot of really good questions and subjects. So come on and listen to us.
All right. We're going to be right back after a short break with some knowledgeable folks from the Walton College of Business.
I'm Hays Waldrop.
This is Garry Skinner.
And I'm Justin Poulin.
A production of 17 Studios. You're listening to Power Supply.
Joining us now is David Dobrzykowski, Associate Professor and Director, Claudia Rosales, Assistant Professor, and Andy Balthrop, Research Associate at the University of Arkansas Sam M. Walton College of Business. We're going to do a little round table introductions, but we're going to be talking about inflation in healthcare today and how that has impacted supply chains all across the country. And so let's start with you, Andy. Talk a little bit about your role at the university.
Yeah, so I'm an economist here within the Supply Chain Management Research Center. I focus on academic research more widely consumed out there. My focus is in transportation policy and supply chain policy sort of issues, but recently I've been collaborating with David and Claudia on inflation in the healthcare sector because it's become a big issue.
All right, Claudia, and what about your role at the organization?
My name is Claudia Rosales, and I joined the department last year. And although I am relatively new to Walton, I've been working on the healthcare supply chain space for over a decade. So I've been kind of trying to learn more and more about the industry and applying that to my research.
And David, finally, you and I connected on LinkedIn, and mostly because you posted some research and some results on LinkedIn, and you're doing a great job, not only yourself individually, but the entire university and the College of Business in just bringing a lot of data and information out on social media. We love that because we just think it's such a powerful tool for sharing and networking and growth. And we know that there's been an enormous amount of disruption in supply chain over the last several years, and especially for healthcare. And they were already going kind of through this reconstruction of the reimbursement model. So things were getting tight even before all of that happened. And now it's like kind of the whammy after everything with inflation hitting. So welcome, and maybe describe your background and role as well.
Yeah, well, Justin, thanks for having us on today. And I thought we connected because I liked your haircut, but I like your logic. I like your rationale a lot better.
I like this guy. This is good.
I like him already.
We're off to a great start. Okay.
Yeah, well, in any event, thanks for having us on today. We're excited to be on Power Supply. My name's David Dobrzykowski. I am a professor here, an associate professor here in the Walton College, where we teach at the graduate level in the areas of supply chain management. We also have undergraduate programming as well. My interest in healthcare was really motivated out of my industry experience. So back before my wacky PhD, I had a 13-year career in healthcare administration, balanced roughly equally 6-7 years on the provider side. And then don't hold this against me, providers, but about 6 or so years on the insurance services side with companies like Bonsic or Mercy on the provider side, and then of course United Healthcare on the insurance services side. So I like to say that I come at healthcare kind of like that guy that has the proverbial devil on one shoulder and the angel on the other, but I'm not really sure which one's which, depending on the day. So that really motivated a lot of interest in improving healthcare operations, working in administration, seeing the disconnected flows of information, material, and financial exchanges. And that's really what brought me to healthcare supply chain and healthcare operations. So for the last 12 years, I've been working in some sort of professorial role. For the last 3 years, I've been here at Walton, which is just an incredible place, the most incredible place on the planet, I think, to study supply chain here in Northwest Arkansas. So thanks again for having us on. We're excited to be here.
We're excited too, David. But I want to, as a child growing up with that last name, at what age were you able to spell your name? Do you know?
Yeah. Well, I'll tell you what, it was a really challenging kindergarten year because I wasn't a particularly large boy, and my name tag was so long with those 12 letters that it kept pulling me over. Actually, is what happened. Honest to goodness, really quick, sorry about this, but my wife's maiden name is Tomaszewski. So on our second date, she looked at me and she said, well, David, I could never marry you. And I said, well, it's our second date, Sarah, but you've intrigued me. I'm curious as to why, you couldn't marry me. And she said, well, I'm looking for a man that can do two things for me. One, shorten my last name, and two, move me to the beginning of the alphabet. And I said, well, I'm half the man you're looking for,
See, off to a wrong start.
I'm glad you didn't go with a hyphenated last name.
Oh my gosh, I was thinking about the hyphenation.
Well, she's an attorney, and they initial everything that they work on, right? And she was a little concerned about her Sarah Tomaszewski Dobrzykowski initials doing that. So she opted just to take my last name.
You don't get this anywhere else.
Let's set the table for the conversation about what's going on related to inflation. And I think we can even start on a really high level and just talk about it globally, not even healthcare. And then let's drill into healthcare and start talking about some of the insights that you all have formed from research and that you've published. So whoever wants to start is fine, but tell us a little bit about the state of inflation. I know we see it on the news almost every day lately.
Well, we're blessed to have, a leading supply chain economist, with us today and on the team, Andy Balthrop. So, Andy, why don't you take that one?
Yeah. Well, so in the past 6 months, you've really seen this start to develop on the consumption side of things at the end of the supply chain, as it were, is that you're seeing 8 or 9% inflation, the past 2 months. The last month was a little bit lower. I think it was 8.5% as measured by the consumer price index, which is, an index of kind of the standard goods that a consumer buys. But before that, and if you look at producer prices, it's that we've seen that spike for more than a year now. And so you're kind of seeing this be a really interesting sort of supply chain shock that's kind of rolling through the system right now, that about a year ago is that you have really substantial increases on production costs as measured by the producer price index. It's been around 20% for a year or more. And so it's only within the last 6 months that this is really, from a global perspective, right, is really starting to show up on the consumer side of things. What's been really interesting, and we've been talking with a lot of supply chain people in the healthcare industry, is that these producer prices and consumer prices, it's really sort of created a vice a lot of hospitals are starting to get caught in. Because while consumer prices have gone up about 8% year over year in the past, if you were to look at last month's data, hospital prices or healthcare service prices, what they're charging consumers, is only around 3 or 4%. So it hasn't been, those prices, of healthcare services, what they're charging to end use consumers have not been accelerating as fast as, overall consumer prices. And they certainly haven't been accelerating as fast as the input costs have been for healthcare providers. So that 3% price increase on that final side versus, the cost increase at 20% or more has really been squeezing healthcare providers.
Yeah, that's a great point. And, that's really a condition of the nature of how the industry, engages in contracting, right? I mean, hospitals and healthcare providers obviously receive the majority of their reimbursement, not from self-pay patients, but through the federal government, through Medicare and Medicaid, the CMS, as well as through private payers. Well, those contracts are at least annual contracts, right? So, I mean, as your costs increase on the inbound side, think of it that way, you have very limited capabilities on the outbound side to adjust your revenues as a hospital.
So do you think there's just a 12-month lag here?
Yeah, that's an interesting question. So we've talked with many CSCOs at large health systems, as well as folks on the medical surgical distribution and supplier side of things. And here's the fundamental problem, right? I mean, as you mentioned in the intro, through value-based purchasing and, outcomes-oriented reimbursement methodologies, that's been a great way to incentivize hospitals to deliver better care, but it's also produced lower costs, right? I mean, the aim was always, over the last 25 years that I've been in healthcare, right, to try to reduce costs while improving quality. So, the likelihood of hospitals and healthcare providers being able to actually increase up rates is really not a promising type of outlook. You think about how the industry is structured also, right? While there's been tremendous aggregation and consolidation, you've seen integrated delivery systems emerge and grow over the last 20 years. The reality is no one health system really possesses the clout, right, to have an effective negotiating position with large payers or certainly, federal government payers. It's not a situation where a retailer, let's say, has 6,000 stores, located in every corner of the United States, right, and has that kind of a leverage, right? Hospitals simply, don't have that kind of negotiating clout.
Something to remember, because you mentioned also, let's talk about it prior to the pandemic. And even prior to the pandemic, we were seeing healthcare institutions really being kind of squeezed a little bit in terms of cost. When you think about healthcare providers, their first expense is labor, and the second one is supply chain. And there have been really a lot of efforts because of changes in the payment structure to really become a lot more efficient than they had been in the past. And they were really trying to, again, respond to this in many different ways, becoming more efficient, becoming more consolidated. So there have been ways in which they have been trying to reduce cost. But still, if you look at the fact that most hospitals in the U.S. are not-for-profit institutions, they operate on very thin margins. So any even relatively small increase in supply chain costs or labor costs will have an impact on their bottom line. And they kind of came into the COVID pandemic with this kind of already tight, let's say, situation in terms of cost. And then, boom, we got the pandemic.
I was just going to throw this out there, and what concerns me a little bit, and it makes sense kind of what you said there, Andy, was that, hospitals certainly, their revenue is flat, if you will, but, and they're starting to see a little trickle up in prices. But in the last week, I've had 2 conversations with 2 capital equipment companies, and they're getting ready to bring double-digit increases to the market. And obviously, with so many health systems right now just really struggling, there's going to be a point where there's a lot of friction. And I don't know what's going to happen there, but I maybe be curious to see what you say about that. What will happen? Do you have a guess?
Andy can probably speak to this from a data perspective, but I can just tell you from the interviews that we're conducting, CapEx has really come to nearly a screeching halt in healthcare. Construction projects, new medical office buildings, new bed towers have really come to a major, kind of slowdown. And the same is true from a capital expenditure perspective for capital equipment like diagnostic imaging stuff, like think about MRIs and CTs, PET scanners, and so forth. a lot of those major 7-figure purchases have really slowed. So while that's true on the input side, if you're a hospital, the prices have gone up. The reality is, unless you really need this equipment, I think hospitals are slowing their purchases in this category. One exception, of course, that we're seeing in our data is in the area of laboratory. Laboratory year-over-year inflation is actually around, I think, 7 or 8%, which was considerably larger than, say, general medical surgical supplies. And as we talk to people and we ask, well, why do you think that is? Some of the feedback that we're getting from CSCOs at health systems is, well, think about it, right? With COVID, that's one area where we needed a lot of support. We needed increased infrastructure, was in diagnostics and tests, lab equipment. And frankly, you can make a better business case for it, right? When you see volume increasing in that way.
Being wishy-washy here is that, like, one of the things that I think we'll talk about a little bit more through the course of this is what we're really getting is that these inflation averages kind of cover up a lot of uncertainty that's going on right now, and a lot of uncertainty about what you'll be able to get, a lot of uncertainty about what you'll need to treat patients with, about what the patients are going to come down with in the next year. And so the incentive is to delay the things you can until that uncertainty resolves itself there.
Let's talk about that a little more in detail. Why wait? Let's have that conversation. It makes sense what you're saying about lab, right? There's volumes there, et cetera. So, but you're kind of saying that there are some things to be concerned about that might be blind spots for a lot of people because of that uncertainty. What are those blind spots? What do the listeners of this podcast need to have in the back of their mind that they're watching, and what should they be potentially planning for? Like, nobody has time to necessarily lay out strategy for things that aren't going to happen, but nobody can suffer the consequences of taking a reactive approach to solving those once they hit. So I'm thinking, KPIs around some of these blind spots, indicators that they can be looking out for that all of a sudden says this area should become a priority because now it's moved from maybe 10% uncertainty could happen, might happen to now we're above that 50%. There's a good chance this might happen. And this probably is a 2-hour conversation, but maybe pick a couple of good ones.
Yeah, well, one interesting thing. So we're aggregating all of these LinkedIn posts that we've been doing on economic inflationary impacts on healthcare supply chains. We're aggregating them into a white paper, and we're doing a bunch of interviews with industry leaders. And one thing that I think has surprised me, and maybe Claudia can talk about this too, is that we've gone into these interviews thinking that cost and inflation was going to be the number one issue that they faced. But every single one of them wants to talk about disruptions, right? There was a CSCO from a large health system this morning that we spoke with who gave me just a great quote. And what he said was, look, David, the cost of a back order is much greater than the cost of a widget right now. I thought that was really, really powerful. And I think that speaks to some of the uncertainty that Andy's kind of talking about there.
Mm-hmm. Yeah, it's an interesting problem that they're in because we're all seeing all of the supply chain disruptions. We have personally experienced not being able to get something we want. But when we experience that, let's say I go to the store and I don't find a particular brand, well, I simply buy another one. It's not typically a big issue for us to substitute products. But in healthcare, that's not the case. And not only when they don't have something, it's not that easy to substitute. Why? Because they usually don't have a lot of manufacturers for the same thing. Barriers to entry for an industry like this. So it's very common to see that certain, medical supplies are manufactured by a couple of companies around the world. And when in addition to just being manufactured by a few companies, they have all of their manufacturing in the same geographical place, then you have a recipe for disaster. Because if something happens, whether that area enters into lockdown or they experience a hurricane or there is war or whatever it is, then suddenly, if you only have 2 manufacturers, you lose 50% of the supply in the market. And it's not like it's going to be easy to get somebody to pop up in the market next month and supply for, that demand. So it becomes a difficult scenario. And when you're thinking about the fact that they cannot simply just stop providing patient care, we've been hearing, In healthcare, it's been common, even prior to the pandemic, to have a lot of shortages, especially in drugs. But now they're seeing a lot of that in medical supplies, and recent examples have been contrast media. They were really struggling getting contrast media a few months ago. Now we're hearing about test tubes, for blood samples. What do you do if you don't have those things? A hospital has to operate.
Are those materials coming from overseas? We literally just had a conversation the other day, and we're talking with a manufacturer, and, this particular individual that we interviewed came from food. And the substitutions piece was a big part of that conversation, that there was more flexibility than you see in healthcare. But are these materials, like for contrast media, coming from overseas?
Well, so that's a great point, right? Especially when you put this in the context of the conversation that's been happening over the last 18 months around resilience or resiliency, right? That we should nearshore or reshore everything, that we should keep more safety stock, that we should multi-source. In other words, engage in a lot of very expensive approaches to build resiliency. And the reality is, I hate to be an academic, but it depends. Okay, and what it depends on, are things like what is the source, right, of the disruption? Like you're talking about contrast media. If it's a raw material per se, well, that might be something that's offshore, and that might be a truly global type of disruption. But there are a heck of a lot of plant fires that we hear about here. A supplier this morning told us about a roof being torn off of one of their facilities, by a tornado that put them down here in the United States. So, it's not necessarily a situation where reshoring is the silver bullet. And the other thing to consider is that reshoring is not cheap. It's not free. One of the posts that we did recently showed that domestic goods increase for hospitals is about 13.3% increase year over year, while imported goods is only about 7.6%. So you're paying like a 5%, 5.5% premium, right, for that domestically produced good as well. So, you're in a situation here where probably geographic dispersion, a geographic approach to where you source is probably important from a risk mitigation perspective, but realize that these approaches are not free.
Good point. Really good point.
Totally. Well, since Justin took my OTO question that I was going to roll right into, he just rolled right into it. I just feel good. I'm thinking like Justin, so I feel good about myself. So I actually built my self-worth. So anyways, right now, August 18th, 2022, I got to bring it up. Supply chain, we're talking about supplies, we're talking about costs, we're talking about payers down the end. Contracted labor is a giant piece of this puzzle right now. And I think about the OR specifically. If we can take it down to an OR that, say it had 10 ORs up and running, and now because of contracted labor, elective surgeries, commercial payers, where a lot of their money comes in, a lot of the money to support these hospitals. And now you don't have clinical support nurses, if you will, or you have contracted traveling nurses or higher cost, if we will. We need it, right? We need it for patient care. We need it for our baby boomers coming in. That scares me a lot. Want to hear your perception on what your thoughts are on the contracted labor force moving forward with the inflation and how that's going to affect it, maybe some solutions or ideas or what you're hearing. So.
Yeah, well, you're totally right. So on every one of these calls, one of the key learnings, of course, is that labor is the number one hot button issue. What I thought was really interesting in a lot of our interviews is that it's becoming a hot button issue for supply chain leaders. Historically, this was an HR and a CFO type of problem, right? But health systems are increasingly using supply chain because of their expertise in procurement and contracting, strategic sourcing, and so forth. They're taking input from the chief supply chain officers in the supply chain function, which I think is really, really terrific. One health system we spoke with yesterday actually said, we're really proud. We were one of the last ones to have to close down a service line because of labor. And I thought to myself, back in my hospital days, man, that would kill me to close an OR, right? Or close down the cath lab. Oh my gosh. So I think the thing to think about too is that when you've seen one category of labor, you've seen one category of labor. And that is that across healthcare, not all categories, react the same way and act the same way. Here's an example. Take a guess, right? We're professors, so we're going to quiz you, right? What do you think has the highest year over year increase in labor costs? Would it be residential nursing homes, hospital employees, ambulatory services, so outpatient types of facilities, people that work at outpatient types of facilities, or social assistants?
Does it depend on what?
I'm going nursing
I was going to say it
homes.
depends on what news station you watch. That would have a lot to do with which one's really having inflation or not. I don't know.
NBC versus Fox, is that what we're talking about? Okay.
I love how smooth Hays is at completely dodging being wrong.
Jeez. Are you running for office, Hays? He's running for office.
like
Hays.
this
I'm just
year
going to
all
jump
over
all
again.
in. I'm going long-term care. Come on, this is the Alex Trebek moment.
It is long term.
Oh, I
It
already
is,
got
Justin.
it. See, you guys didn't even get a chance to be wrong.
We're going to have to give you an honorary doctorate here, Justin, I think, because you're absolutely right. And when we try to unpack that, we ask, well, why would that be? What providers are telling us is, hey, think about it. This is a very difficult job. For a lot of folks, it's a very unattractive place to work. You're emptying bedpans. You're doing things that are, people don't wake up in the morning on fire to do, right? And if I can make the same amount of money, here's a quote, right? If I can make the same amount of money working at Chipotle, I'm going to go do it. So, that I think that's one real reason. So when you think about the nature of the skill set that's required in the job, the specialization and the job demands, these are all factors that are going to drive which categories are more mobile than others.
So I worked in that setting, David. I was a CNA while I went to nursing school, and then I worked as a registered nurse. And, they were the lowest paying, in that job section. And so everybody started there, but with the intent of getting into a hospital setting or home health or some other area. And some people would stay, but for the most part, it was a leapfrogging kind of work environment. And I also know that they tend to be resource starved. And then I also know that because they didn't really have the same infrastructure for managing airborne pathogens in those settings, that they were also some of the hardest hit during the pandemic. And so when you combine all of those factors, it's kind of a no-brainer. They needed more staff. The staff wasn't there. Most of them didn't even have infection professionals, even part-time or on call. And then all of a sudden they had this major infection control problem that they had to address. And then where did you get those people? Because even the hospitals were understaffed in IPs to begin with. And a lot of them were nurses at end of career that said, I'm not going to keep going into the hospital. I'm risking my life. And so not surprised to hear long-term care at all.
Well, Justin, thanks for doing what you've done. I mean, that's just a tremendous service that you played in that role. I mean, as a consumer of that with two elderly parents, I've got to tell you, it's a difficult job, and I appreciate what you've done. But you're absolutely right in terms of your observations about the trends. It's not just the fact that long-term care has had the highest increase, just under 10% year over year, but it was also the first to spike, right? I mean, if you look back, those spikes were happening in early days of the pandemic, March, April of 2020, while hospitals really were probably delayed by almost a year on a lot of those increases.
It's been higher throughout, right? So this stuff is just a product of that spike there, but there's been shortages there for the past 2 years.
Yeah. Most folks that we're talking to, so we end all of our interviews, right, with the question of, well, what's the future look like, Jack, Jane? I think, and Claudia and Andy, jump in, but most folks are, I think, telling us that they feel inflation and a lot of these effects are here to stay. Like, they're not planning on a better day. It reminds me a lot of the conversations I had with non-healthcare supply chain leaders, over the last 2 years of the pandemic. It was like they were working for an endpoint, right? They were saying, it's going to get better. Just work your tail off. In 6 months, we'll be okay. In 8 months, we'll be okay. In a year and a half, we'll be okay. And there was a tipping point, maybe almost a year ago, where supply chain leaders, like in our area, the folks that we work with a lot, said, you know what? This is, I hate to use the cliche, but this is the new normal or close to the new normal. We need to learn to operate in a highly uncertain environment where we need to be extremely agile. That's kind of, I think, where a lot of healthcare leaders' minds have come to. I don't know that they're waiting for the end of this.
I was going to ask you too, just on the conversation that you've had, and thank you for being kind of on the front edge of this on the academia side, putting it out and getting white papers and collecting all this data, because I think it's huge. But are you finding the vendor communication that supports our hospitals I'm finding that they're coming through with surcharges, they're coming through with increases, they're bringing it up. But I'm also finding some of these larger vendors, larger partners, if you will, in these healthcare systems are actually finding ways to be creative and help. I'm finding that. What has been your experience on both what you're seeing on the inflation they're just passing along because gas costs more, and on the other end of the spectrum, are you seeing that they're stepping up to play a little bit more to help?
Yeah, well, I think that's a great question. And what this environment, has been doing from a relationship perspective is really an interesting one. And again, I think it depends. I hate to be a professor. I think it depends a bit on who you're asking, right? Because if you're at the distribution tier in the supply chain, there are a handful of companies, right, that control 85% of market share. And in the last 3 years, there have been some winners in that from the perspective of moving business. And there have been some folks that obviously that business moved away from. So, when we talk to folks, we hear comments like, there's never been a worse time to be an incumbent distributor in healthcare, because the first time that you have a substitution, right? Well, then your hospital, client is looking to another distributor. And sometimes those distributors or manufacturers even will sell direct, shifting inventory from other dedicated accounts just to, try to put a good face on, with a prospective account. That's one view of it. Another view that we've heard frequently is there's never been a better time to be an educator as a distributor of your hospital clients. This is a great time to help hospital supply chain folks understand what's driving disruptions, what's driving cost in our industry, and to really add value and solidify strength in the relationship.
When you say add value, are you talking about adding staff in some cases and taking responsibility and workload, since we know that supply chain trending wise was understaffed before this happened, right? And with the development of all these different, there's now materials management, there's value analysis, there's strategic sourcing. The rise of supply chain to the C-level conversation also meant there wasn't enough people at the right level of training to be able to fill these vacancies and continue to drive forward. I almost feel like if you go onto LinkedIn and I do this, if you go onto LinkedIn and look to make connections in healthcare supply chain, you're going to find half the people on LinkedIn are consultants. And I think it has a lot to do with that kind of scenario, right? So I'm starting, and a lot of them also work for GPOs, but I'm thinking that at this point, the industry is going to start looking to suppliers to not quite like outsourcing like you might think with food services or linen, but almost outsourcing from the perspective of added value on the contract. Like, what are you going to do for us on an operational basis day to day at this point? Because we don't have the staff. And especially when you start talking to these hospitals about transitioning to a new service or a new product, they're going to tell you, and I've had enough of these conversations with supplier organizations, they're going to tell you, I just don't have the bodies. I hate this cliche, the juice isn't worth the squeeze, but that's become the most common phrase in supply chain now is, you've got to show me 6 figures isn't getting it done anymore. You got to start getting towards that 7-figure mark to make a change. And the truth is some of those 6-figure changes still have great benefits for the patient, but quantifying that is very difficult for a lot of these suppliers.
Yeah, I totally agree.
Yeah, you kind of following up on that, and the fact that this industry is so interesting and the supply chain in healthcare is so different than in other industries, because you have so many players. You have the manufacturers, you have the distributors, and you have the group purchasing organizations, you have the providers. And the way most systems usually operated prior to the pandemic was they had very little visibility, if any at all, of what was going up in the supply chain. They would talk to the distributor, they would contract with the GPO, and most of the time that was it. And then when the pandemic hit and they didn't have PPEs and nobody had PPEs, and they had no idea sometimes where all of this product was coming from, they realized that they needed to be able to have more visibility in the supply chain. And I think those added services that you're mentioning, it goes in so many ways, not just savings, but just bringing more transparency to the supply chain, helping them build more resilience, maybe holding some inventory for them or dedicating some capacity for them, are ways in which these suppliers can probably, strengthen those relationships with providers. But I don't think that the supply chain is going to go back to exactly what it was prior to the pandemic. I think they're realizing the need for more transparency, more communication, really getting not just, yes, we'll have it next week, but truly getting an idea of what's going on around the world and being able to make more informed decisions because they have more data.
I think the transparency, to your point, Claudia, has been great. That, the last couple of years, I do think companies have done a much better job of kind of saying, okay, I'm not going to have a product for 3 weeks or whatever. But I'm going to go right back to where we kind of started, which is my concern of this whole thing. Yeah, you can raise your prices. You can do whatever you want to and, maybe sub out a product or two if you can. But when it goes back to the revenues of these systems, I mean, the numbers that are being reported, guys, if y'all know, are absolutely outstandingly bad. There was one, I think, Northeast that was like $600 million loss. I've got dozens of guys I talk to who are losing, anywhere from $4 or $5 million a month up to 20. And so regardless of if I can raise my price or two, but can they pay for it? We've got to get that part. And I think that goes back to labor too.
We were hearing, about labor specifically. As David mentioned earlier, it's one of their main concerns. And during the height of the pandemic, as you also mentioned, prior to the pandemic, there were already, a lot of vacancies that they were not able to fill up, especially in nursing. But now they're seeing all across the board. It's nurses, it's technicians, it's pretty much in every category. That is still happening to a degree. What they have been telling us is, while they saw a huge increase in particularly contracted costs during the pandemic, some of that is starting to come down, but certainly not to pre-pandemic levels. And when labor represents their highest expense, even if it's a modest increase in this category, it's going to have a huge impact on their bottom line. And it's definitely not a sustainable situation. We had this discussion prior to this podcast. What are they going to do? And some of the things we are hearing is that some of these providers are, thinking we're going to have to ask the tough questions. What can we really cut? What things can we stop purchasing or maybe services not being offered anymore? Hopefully we're not going to get to that, but I think there needs to be some reevaluation at the government level maybe.
Thank you so much for going there, Claudia. But I want to know, I don't want to say government bailout. I don't want to use that word, but I do want to ask, is Medicare and Medicaid going to adjust something? Is this going to the legislative level? It's getting there because I have goosebumps talking about this, uncomfortable goosebumps, because you can only cut so much service lines before you bleed out. I mean, you can only do that so much, and then you reduce the quality of care in a certain community, and then you have, David, to your point earlier, then you're traveling further to go see your parents that you're taking care of, and all of a sudden you're driving 200 miles, and now that community is absolved of those service lines, and now we don't have them. So it makes me uncomfortable. It makes me concerned. It's for the mission, it's the mission of the patients, and we're ultimately hurting those patients when we cut those service lines. So my question is, how long before we keep going down this road in 2022 and into 2023, and we need legislative support of that, and where do you think it's going there? I'll ask that question to this group.
Well, and just really quick before Claudia answers, don't forget the fact that in many communities, the healthcare provider is the largest employer.
Yeah.
In the
absolutely.
So
trickle down effect.
The provision of healthcare is a big part of creating not just healthcare resilience, but community resilience. So I think that's an important thing for legislators to remember as well.
Yeah.
Do you have the crystal ball on legislation?
I certainly don't, and I don't have anyone from that area asking me when I think they should be doing this.
I just think it's real. I think it's coming.
Yes. And I hope that it happens, and I hope that they don't wait too long. The situation has been tough for hospitals. They, as David was saying earlier, we started 2020, the pandemic, and then everybody thought, 6 months or a year we'll be out of this. It's been 2 years. And of course, the pandemic has been getting better, more manageable. But we have, as a byproduct of the pandemic, all of these supply chain disruptions going on that are causing product shortages for hospitals, that are increasing the cost, how much they're spending buying stuff because they need to buy more expensive substitutes. They're having labor issues. So the costs have not gotten back to what they were in 2019. And unless that happens quickly, because the reimbursement is not going up, unless they can come back and be on the red, some of these systems may have to close. And I hope that it, that some action is taken before something like this happens.
But hey, the silver lining is PPE is almost back to normal.
Oh my God! Yeah, go up in the attics of all these hospitals and go, oh my gosh, this is stocked for 5 years.
It's in the ceiling tiles. You remember?
Dude, it is. Oh, geez.
Garry, I think your question, though, from a legislative perspective, at least at a federal level, really has an opportunity to expose the high level of variance that exists in how healthcare is organized and delivered, in a regional sense. Because, anybody that's traveled around or done any kind of research at all realizes that healthcare in one marketplace is completely different than healthcare 400 miles away. So what it means to a small community with a single community hospital or even a critical access facility is very different than what it means to even a community with 750,000 people and 2 tertiary care centers and a children's hospital and 3 helicopters. And, so I think, there's an opportunity to look at this issue that you're raising, which is a really great issue. But to think about what does it mean in terms of how we create a little bit more standardization across the country.
Yeah. And the question, Garry, you asked was very high level, but it could be state level and federal level, types of requests and understanding. And some states are more financially, stable and viable than others. And that's where the federal has to come in and kind of do their part, is to that point, create that standardization and level out that field. Whereas the state level kind of needs to make sure that the people who live in that state, are taken care of. And we're kind of at the end of the time, and I feel like we're just warming up on the conversation. And that we're probably 12 minutes longer than most of our interviews. And that's because there is so much meat on this bone. And I feel like we could
part two.
Yeah, there's definitely a part 2 here. There's also a lot of other research that might not even be related to inflation. So I can see you all being repeat guests on our show. We could never even begin to have an in-depth conversation on some of these topics in 40 minutes. But I got to say, I think one of the things that you all did very well was to really characterize the situations, right? It's like we had lots of good detail in this conversation, but I think you really painted the picture nicely, which, it's great to have research. But if you can't explain the research to the people who need to use it, then it doesn't do anything for anybody. And I heard that loud and clear from all 3 of you today as we talked was, yeah, here's the research. But the fact that you could really connect it to implications and paint the picture of what's happening today for everybody so that they can relate to that information is phenomenal. So why don't we do this real quick before we wrap? Tell them how they can find more information from y'all.
Thanks a lot for having us on. We really appreciate it. If you'd like more information, please follow us on LinkedIn. We do regular posts. That's how Justin and Hays and I connected. We also obviously are on the web. We have a fantastic Master's of Science in Supply Chain Management that's delivered both online as well as in an executive blended format here in Northwest Arkansas. You can find out all that you'd like to know about it on the website. And, I think, those are the best ways to track us down. You can never hide as a professor, okay? Because as long as if you can spell Dobrzykowski, you can find me.
I found you. And let me just say, for the people listening with us right now, the information that you are putting out there is really, really good. And so I do encourage you to, if you're listening, go find it, and you'll see it through one of our links as well. But you do really good work, all three of you. We appreciate what you do for supply chain. Thank you.
Well, thanks for having us on. We appreciate the opportunity. We hope to visit again.
That was Andy Balthrop, Claudia Rosales, and David Dobrzykowski with the University of Arkansas Sam M. Walton College of Business, talking about inflation, the impact on healthcare. And honestly, I couldn't even begin to summarize the awesomeness that was this interview. This was really excellent, Garry, and so many things to think about. And I'll just kind of, give you some props for your, last question there as we were wrapping up. But you're right. At some point, we're going to hit a critical mass here. And, we're going to have to figure out how every party that has a stake in delivering care to patients finds a way to be viable, or otherwise we start watching a lot of things close because they're just not viable.
Totally with you, Justin. I know we joke and laugh a lot about on Power Supply, and that's our focus, to have fun. But this is serious. It's a little bit scary of where this is going to go in the next year, and it's all about mission. It is. It's all about our patients, and if we can't take care of them locally and them having to go further away, and there's that downstream effect that David brought up. And man, I just really think we hit the tip of the iceberg with their conversations. They seem to be on the forefront of a lot of this information with what they're putting out in their white papers, and just the conversations with Claudia, Andy, and David. I want to do it again because we're going to be in this for a while. So great conversation, great detail, and just a great interview. So thankful to have them on here.
Yeah, and if anybody wants to be able to reach out to them and doesn't know how to find them on LinkedIn, or we can facilitate any kind of an introduction so that you can get the research, certainly send an email to info@powersupplymedia.net, or find any one of us, Hays, Garry, or myself, right there on LinkedIn, and certainly just send us a message and we'll get you connected. That's going to do it for this week's episode. But as a reminder, you can help support Power Supply by subscribing on Apple, Amazon, or Google Podcasts. We're also available on Stitcher, iHeartRadio, Spotify, or simply search for Power Supply on your favorite podcast application. We also have bonus content for certain episodes, but to get it, you got to download our smartphone app for iPhone and Android. And while you're there in the marketplace or the App Store, we'd certainly appreciate a rating and a review, because your feedback is important to the show. On behalf of Hays, Garry, and myself, thank you for listening to this week's episode of Power Supply.